So probably the most important part of this chapter is the thyroid nodule, which is the commonly identified discrete lesion within the thyroid gland. And up to 5% of women and 1% of men in iodine-replete areas have palpable thyroid nodules. And with the advent of ever-improving high-resolution ultrasound, the frequency of thyroid nodules has been estimated to be as high as 19% to 68% due to imaging's ability to pick up non-palpable, incidentally discovered thyroid nodules or incidentalomas. Although thyroid nodules are quite common, the majority do not require extensive or any workup, and the vast majority do not require surgical intervention. The primary reasons for surgical intervention for thyroid nodules include concerns for malignancy, hyperfunction, and local compressive symptoms. The management of thyroid nodules and thyroid cancer is subject of much active research and controversy. Multiple organizations have published clinical practice guidelines over the past 25 years. The American Thyroid Association guidelines were first published in 1996 and updated over the years, most recently in 2006, 9, and 15, and arguably remain the most comprehensive, current, and cited among thyroidologists. Much of this section will reflect the evidence and recommendations contained in the most recent iteration of the ATA guidelines. Let's start with the clinical presentation and workup. The majority of thyroid nodules are benign and asymptomatic, and as mentioned above, many are now diagnosed as incidentalomas. Several clinical findings and history and physical exam raise the suspicion of thyroid cancer. These include patient age younger than 20 years or older than 70 years, male sex, local compressive or infiltrative symptoms such as hoarseness or dysphagia, firm and or immobile nodules larger than 3 to 4 cm, cervical lymphadenopathy, history of neck irradiation, and history of thyroid cancer in the first degree family members. In addition, although less common, the suspicion for a hyperfunctioning nodule or toxic adenoma is raised when there are symptoms or signs of thyrotoxicosis, including palpitations, atrial fibrillations, anxiety, insomnia, weight loss, heat intolerance, diaphoresis, and increased defecation. The workup of thyroid nodules typically includes assessment of thyroid function with serum TSH as a screening test, as well as neck ultrasound. The finding of a suppressed TSH level also may trigger further workup of hyperthyroidism as detailed above, including thyroid antibody workup and thyroid nuclear medicine scintigraphy. Further workup for malignancy always includes FNA biopsy, and depending on concern for locally advanced or metastatic behavior, may include cross-sectional imaging. The majority of thyroid nodules are benign neoplasms and include colloid nodules, degenerative cysts, nodular hyperplasia, and follicular or Hürthle cell adenomas. The most common malignant diagnosis is papillary thyroid carcinoma, and in decreasing order of frequency also includes follicular thyroid cancer, Hürthle cell cancer, medullary thyroid cancer, poorly differentiated thyroid cancer, and anaplastic thyroid cancer. Other rare malignancies including primary thyroid lymphoma and metastasis to the thyroid gland can occur. Now, what about the ultrasound evaluation of the thyroid nodules? Neck ultrasound is the most important radiographic study for the evaluation of thyroid nodules. Ultrasound offers the highest resolution image of the thyroid gland by well characterizing parenchymal nodular abnormalities. It also provides the most sensitive radiographic assessment for cervical lymphadenopathy. Ultrasound is also an essential adjunct for the performance of image-guided FNA biopsy of suspicious nodules and lymph nodes. Other advantages of ultrasound include its portability, absence of the need for ionizing radiation, and overall cost effectiveness in the initial evaluation and long-term management of thyroid nodules. Lastly, neck ultrasound has been shown in selected patients to be a useful tool for non-invasive assessment of vocal cord function, which is important for informing surgical management. For patients with hyperthyroidism and thyroid nodules, both nuclear medicine thyroid scintigraphy and ultrasound are recommended in order to determine concordance in presence of possible toxic nodules, as well as to assess for other cold or non-functioning nodules. As neck ultrasound has become more accessible to clinicians and viewed as an extension of the physical exam, it has become more widely used by surgeons and endocrinologists in addition to radiologists. However, because the operator dependence of this modality greatly affects the quality of ultrasound exam, efforts have been made on the national level to provide standardized educational and certification pathways for ultrasound expertise for surgeons. The American College of Surgeons offers a two-step advanced neck ultrasound training program. The need for proper education and standardization is especially apparent considering the number and degree of findings that one must assess for and document in every ultrasound. These findings include at minimum the following: parenchymal pattern and overall thyroid gland size, presence, size, location, and characterize of any nodules, and presence or absence, size, location, and characteristics of any suspicious cervical lymph nodes. Survey of the cervical lymph nodes is particularly specialized and important in the evaluation of thyroid nodules. The level of the neural stations in the neck has already been discussed in the previous video, in which we discussed about the anatomy of the thyroid. So these are the numerical nomenclature which is created for neck dissection examination for head and neck cancers. Thorough examination must be performed particularly of the pretracheal and paratracheal nodes of the central neck and mediastinum, which is in the levels 6 and 7 respectively, as well as the lateral jugular chain nodes, which are the levels 2A, 2B, 3, 4 and 5B.